Recording in progress.
Thank you for joining GM Insights. We're going to have a few minutes to get started, and thank you for joining. Dr. Lauren, it looks like we have 25 people ready. We can get started right now if you're ready. And I'll do a quick
go
intro.
ahead and get started. Perfect. Thank you.
Wonderful. So thank you everyone for joining. I'm Emma Matovu. I am helping introduce our speaker today. Dr. Johnson is out today, unable to join us due to a conflict, but it's a pleasure to have Dr. Lauren join us. He is a professor of neurology and director of the neuropsychology program at Emory and past president of the International Neuropsychological Society. His work focuses on developing and applying neurobehavioral assessment methods used to evaluate treatment effects, procedural risks, disease progression, and to improve the precision of behavioral phenotyping for more accurate patient characterization. Dr. Lauren earned both his master's and doctoral degrees at the University of Houston. His January 2022 lecture, Lessons Learned from the Clock Drawing Test for Cognition, is the most viewed video in the GM Insights series with 1,600 views. Wonderful. Thank you so much, Dr. Lauren. You're up.
Okay, thank you very much, Emma. And thank everybody else for joining today. It's always a pleasure to do these things. I think this is my third time presenting to the group, and it's always fun to put things together. Today, I'm going to be talking about some of the most common errors associated with the MoCA test. Just by way of formalities, I have no financial or any other relationship to disclose with respect to this presentation. And more importantly, none of the planners for this educational activity have any relevant disclosures to go forward with. So I'm going to be talking about common errors, and I'd like to take a little quick survey as we get started to see what everybody thinks in the group. What do you think is the most common MoCA error? Treating it as a comprehensive cognitive evaluation, overinterpreting individual responses or domains, relying on fixed cutoff scores, or assuming a normal score equals normal cognition.
Poll is up. Participants are voting.
Okay. Now, while everybody's voting, of course, I have no way of knowing what is the most common. And what we're going to do today in the presentation is kind of hopefully touch base on all of these and promote a little bit of discussion and at least some review and thoughtful characterization as we're giving this test.
Here are the results.
Yeah, I see the results, and I'm happy to see they're all good. Like I said, I think we're going to talk about all of them to varying degrees in this presentation today. Okay, so let's get started with a quick overview of the MoCA itself. The MoCA was designed as a screening tool, and that distinction is really very important for how we interpret the results. You know, by design, screening tools are built to maximize sensitivity. They're designed to catch as many true cases as possible, which inevitably means they also flag a number of people who don't actually have any cognitive impairment. The MoCA covers several cognitive domains, but only very briefly, kind of ranging between 1 and 5 items per domain. And importantly, the factor analytic studies that have been performed over the years on the MoCA demonstrate that the labels that are applied and are commonly used really aren't all that accurate, with executive function and memory being the factors that generally pop up in those studies. The recommended cutoff for the MoCA is generally 26 or below. Now, the MoCA itself was introduced by Nasruddin in 2005. You know, up until that time, the mini mental status examination, the MMSE, or sometimes for older people called the Fulstein, had been really the most commonly used cognitive screeners, but for a variety of reasons, one of which is probably the fact that the MMSE was now being charged and was no longer freely available. the MoCA has gradually become, for many places, the kind of de facto screening standard, although the MMSE, frankly, is still used in quite a number of places still. In comparison to the MMSE, you can see there's really greater group separation. This is from the original study from Nasruddin, where we have the MMSE and the MoCA administered to the same group of patients. These are clinical referrals for memory disorders. And you can see a couple of important things. First of all, there's only a couple point separation for the MMSE in performance between the controls and MCI, whereas this looks like it's like 5 or 6 points. Similarly, there's greater group separation between the MCI patients and the Alzheimer's patients. On both cases, you'll notice, though, there's still kind of a ceiling effect. So what this means in context is the test is not really used to infer normality per se, because it's a very narrow range, but rather it's used to screen to identify possible abnormalities. Using receiver operating curve characteristics, which is fancy statistics to take a look at maximum score to differentiate the two groups under condition, they generated a 26 score as their recommended score because it was associated with really pretty impressive sensitivity of 0.9 and a specificity of almost close to 0.9. At 0.8, discriminating MCI from their healthy controls. Second poll question for everybody here. What do you think is the average control education used in that MoCA validation study? 11 to 12, 13 to 14, 15 to 16 years, or on average more than 16 years?
Poll is up. Participants are voting.
All right. Group average is wrong. Actually, in the control group, it was slightly greater than 13 years. MCI patients were about a high school education, the Alzheimer's patients, 10 years. And this is an important point to remember, and it's a criticism for really all of the control studies, because this is not a test that was developed. I mean, I'm a neuropsychologist, and they have norms, and they go out and they generate things with very nice sampling of populations. This is usually done on samples of convenience, and people who tend to volunteer for any research study tend to be a little bit higher education. So that creates the concern when we generalize from a particular recommended threshold that there may be some sort of a little bit of a group mismatch compared to the populations that we're trying to use and study it with. So where do we see the MoCA errors? Well, there's really two broad categories I'm going to touch base on. One is the administration errors, and probably more importantly are the interpretation errors. On the administration side, probably the biggest issue that many testers we see is many of the testers were never formally certified. Formal certification was not introduced until 2019. So this is about 14 years after the MoCA was published. A lot of people were using MoCA with in-house training in review. According to the website, the MoCA website, only about 1/3 of the people that they took before screening, they considered to demonstrate adequate proficiency with respect to scoring and administration. So it raises concern as to the sites that are using it without appropriate training and supervisions. I'm going to show you some of the errors here that are really quite frequent in terms of what normal, healthy patients may be doing. Now, response errors are frequently seen by cognitively normal, non-clinical patients. And this is really an important thing to realize, too, to the extent that you go in and you try to interpret either individual errors on a particular item or looking at errors that fall predominantly within one of the MoCA domains. On the interpretation side, the most common errors are really over-relying on a single cutoff, treating the MoCA as kind of a diagnostic instrument rather than a screener, and failing to interpret the scores kind of within the bigger picture, the clinical context, referral, and taking into account the patient's background. So let's take a look at some of the real world data. The figures I'm going to be showing you today are from Dr. Law's Emory Healthy Brain Study. As I think many of the people on the call today know, this is really trying to predict which patients who are cognitively normal at the time of enrollment into the study, if we're able to predict who may transition and develop Alzheimer's disease down the road. So examples that I'm showing you are all healthy controls. They're self-identified as normal. They're not referred for any particular cognitive assessment. Now, when I show these figures to you in your percentages, there's no rules of thumb that I know of that kind of says when error frequency is big, needs to be worried about, versus probably reflects normal variation. Thinking this through, that I kind of related to what I do clinically, the 5% or lower is not a big deal. When it starts getting between 5 and 10, it might be worth a little bit of attention. And certainly as we approach 25% error rate, that's kind of a high frequency of impairment. So starting off here, the mini trails is, I guess, kind of moderate. 14% in this healthy Emory brain study failed to get this correctly. But we take a look here at the Necker cube, 25%, that's really a pretty large number. On the clock, 1% is nothing. People can usually draw around clock. But what we see here more frequently is a very high frequency of hand errors. So in my experience, it typically is the fact that, as we see in this case, they're not centered down all the way. And also the hands themselves, the scoring criteria explicitly state they need to be clearly different in their lengths, reflecting the hour hand and the minute hand. Frequently, they're the same length. Sometimes there's subjective criteria as to whether you can meaningfully make that distinction or not. I do want to return back to this Necker cube. I think I said we'll find out that this is one of the most common errors when we do the MoCA testing. Some have suggested, some of my colleagues here at Emory don't like the Necker cube at all because it's failed by such a high frequency of people, and that's undoubtedly true. But while the MoCA itself is designed mostly to take a look at abnormalities, I kind of like the fact that this, when it's performed correctly, gives me greater confidence that there's not really a difficulty in terms of the spatial perception and the spatial ability. So performing a hard task well provides me some informal reassurance of normality. Now, naming errors are rare. Lion, 2%, rhinoceros, 5%, and camel at 1%. Now, again, as I was putting this together and reviewing the data from the Emory Healthy Brain Study, I thought the rhinoceros being labeled hippo was going to be 10, 15, 20% or more, but I was surprised that it's really only around that 5% threshold I was talking about before. I think the common error, since it typically is hippo, it's reflecting kind of the limited background and familiarity rather than any sort of semantic change associated with brain disease. So let's take a look running into the attention ones. Forwards, people pass it quite well. Similar, no particular disproportionate error rate associated with the backwards order. A little bit more with the tapping, attention tapping. And the highest in this domain, not surprisingly, is with the serial sevens. For those of you who routinely give this, people will almost or very frequently say, I can't do that, I can't do math. And there's still this math anxiety that seems to get worse as you get older. So it's not surprising to me that this was relatively high error rate. One of the more striking findings involves the high repetition failure rate of the cat always hid under the couch when dogs were in the room. This is a 31% error rate, as high as any of the ones that we are going to see or have seen. The sentence sounds simple, but repetition must be exact for scoring purposes. So if you omit a word like always, or changing hid to hides, or altering any of those details, it's going to count as an error. Interestingly, sentence repetition is common bedside test that's used in neurology clinics to take a look at language impairment from stroke, and also used to kind of make diagnostic inference of aphasia subtypes based upon the presence or absence of repetition errors. Now, if we come back to the CAT sentence from a linguistic standpoint, it's really a relatively simple one with low phonemic complexity and high semantic predictability. And that actually limits its sensitivity as a phasic or linguistic related repetition items. So this is an example, I think, of one of the mislabeled elements in the MoCA where it's probably better an intention one. And you can also tell too, culturally, different forms of English exist, and anything that doesn't exactly match what was suggested by the scoring criteria from Nasruddin is going to count as an error. Abstraction performance is heavily education dependent. You can see high rates, but I don't think it's particularly a surprise or particularly unusual. Now, the delayed recall items, and I'm presenting here only the free recall component. And the reason I'm presenting only the free recall is that these are the items that contribute to the overall 30-point summary scale that we see in the MoCA itself. Go down the line. It's not surprising at all that many people have failure to spontaneously recall at least one element. So this demonstrates a pretty high error rate, I guess, across all of the different elements. When we go to the last part of the MoCA, the orientation items, date is the highest error rate. I always smile to myself when I'm giving this test, and I ask the patient, what's the date? And then I have to look down kind of into the corner of the computer to see if they're correct or not. So I feel guilty asking it sometimes. And I also adopted a rule of thumb that goes way back to my graduate school days, that I don't want to rely or over rely on cognitive tasks that I myself have difficulty coming up with the correct answer. And this is one of the ones that we see frequently. So I guess let me pull this all together. Across the Emory Healthy Brain Study, we have a high Decker cube error rate of 26%, the hand placements on the clock, 23%, and the repetition. So we can see here that it's kind of these executive function items that tend to be a little bit have more great difficulty associated with that. Delayed memory, this is the combination of all the scores, only 7% get all 5 items on the trial with free recall. So the key takeaway from this is that even with a ceiling effect, errors are seen across all MoCA domains other than orientation. They're all pretty common. So let's turn over to interpretation, and specifically kind of the over-reliance on a single cutoff score. I mean, I'm a neuropsychologist, and I think cutoffs only belong at the beach, but certainly they're widely used in terms of our assessments. The 26 out of 30 cutoff had really become so embedded in clinical practice that many providers really treat it as a bright line or ultimate reality. Either you're above it or below it, so you're either cognitively normal or cognitively impaired. I think the reality of the situation is really quite different from that. Going back to the original Nasruddin study, they identified 26 out of 30 based upon their ROC analyses of that sample. And there were less or fewer than 100 subjects in each of those different conditions. When you apply it more broadly, as with the NAC data set, the numbers look really quite a bit different. A review by Lauren Ratcliffe from the NAC of, I think, multiple thousands of people found very different specificities. So we have a specificity of 68% versus the 0.87 reported by Nasruddin, essentially saying that 32% in this particular sample using those same criteria misclassified as abnormal. more importantly, is there's a big race difference. If we take a look certainly at the white participants, the specificity is 73%. But if we look at the Black participants in this cohort, the specificity is reduced to 42%. This means that over half of the cognitively normal Black adults are misclassified. Obviously, this is really a hugely serious equity issue. So, the fundamental problem is that the cutoff that was derived by Nasruddin is only from a single population. This is Montreal, Canada. I don't even recall how many of these where they came from, but they were derived from one clinical context, and one clinical context or environment by definition will not generalize to all patients and then into all settings. Age, education, language, cultural background are all important contributors and need to be accounted for when interpreting what a given score means. Using a single score for everyone oversimplifies really a pretty complex clinical situation. So one response to this problem has been a recommendation to use multiple cutoff scores. And there's certainly advantages to this. This approach maximizes the clinical utility by kind of reducing the systematic misclassification that we just saw with the Ratcliffe article. The trade-off, of course, is that using cutoffs that favor specificity and reduce false positives also are going to reduce the sensitivity to true cases. So there's always going to be some trade-off between the two of those that need to be factored in when trying to make a specific inference. Now, the cutoff that Ratcliffe reported from that study was a white cutoff of 25 out of 30 and an African American cutoff of 22 out of 30. These were recommendations on these articles, and there's actually a number of different recommendations out there, suggestions based upon different samples and different cohorts that are suggesting something slightly different. But the important message, I think, here is that based upon cultural, educational backgrounds, things like that, there are going to be difference in how various people will perform their tasks.
Yeah, this is a great point, Dr. Lauren. Hi, this is Gabriela. And we see this at Grady a lot. And so many times we see the one point that you add with an educational level of 12 or less is really just 1 point in a scale of 30. So we see that variety, and it's really hard to interpret. So that's something that we see really every day. What to do with a MoCA of 21, 22, what is normal, what is not normal. So your point is really well taken. And race by itself, it doesn't really also, it has variation, but this more is like educational level and literacy level and what you do with those numbers. So this is an excellent topic, and it's really something we see every day here in the memory clinical grading. Thanks.
Mm-hmm. Absolutely. I guess kind of a related issue to changing to the other side of the coin is ceiling effects, particularly in, highly educated or high functioning patients. If a patient scores 27 or 28, what does that tell you? I think for most people, it kind of provides some reassurance of overall normal cognition. But what happens if your patient's a physician, a professor, an attorney, somebody who historically is going to score very high on test taking? A score of 27 or 28 might actually represent some meaningful decline or something to follow up on. Unfortunately, the MoCA really does not have the resolution to take a look at things at the higher range. And again, there's a very ceiling effect that's really not normally distributed in terms of the psychometrics. So that brings us really to probably the most important point I want to make is the interpretive error. And that specifically is treating the MoCA as a diagnostic instrument. It's not a score below the cutoff doesn't confirm MCI or cognitive decline. A score above doesn't necessarily rule out cognitive impairment. Just in my experience, one of the things that I do here at Emory is participate in the evaluation of movement disorder patients for possible deep brain stimulation. And the presence of cognitive impairment kind of guides the candidacy in general, or also might guide where the electrode placement selection is made. In my experience, roughly 10 to 15% have a discordance between the MoCA screening score that we include in our protocol with respect to the more formal or more standardized neuropsychological evaluation. And interestingly, this goes in both directions. Some patients will have impaired set shifting on tests like the Wisconsin card sorting or with the extended trail making test that we have, but have a normal MoCA score. Others have a low MoCA, but do well on our formal neuropsychological tests. You know, although there's a lot of executive function component in the MoCA, and that actually is one of the areas of superiority compared to the MMSE, is still a brief sample. And if you take a full trail making bee rather than many trails, deficits can appear and announce themselves better over time. And similarly, too, the memory test is really a screening test that's quite brief. So let me offer kind of an analogy. I don't know how many baseball fans are out there. We just finished with World Baseball Classic. If you think about a baseball batting average, it's a summary statistic. It tells you something real and useful about a player's performance, but it doesn't capture everything. It doesn't capture all relevant behaviors. A 300 hitter doesn't actually hit 300 every time he's at bat over a game, meaning he doesn't have 3 hits out of every 10 appearances. And importantly, there's really a lot of variability. We have good days and bad days. Doesn't tell you how they perform in other contexts. And I think the MoCA is kind of similar. It's only a sampling of some of the behaviors that we think are relevant. Performance fluctuates. Patients, again, have good days and bad days. And important, like batting averages, it's not an absolute measure of some finite ability. It's not a blood test. It doesn't predict some biological function, but it has inherent instability as well as the performance. So the absence of an implied confidence interval, I think, is good as we see this with batting average, because if you tell somebody the 300 hitter, if they're up a few points or down a few points in a season's batting average, that's expected and there's no worry with that. But when we have a MoCA score, say a MoCA score of 25, people are going to treat that as pretty absolute without considering that it probably represents some variability above and then variability below. So here's probably my favorite slide. It's an illustration of the baseline problem. Again, as you've all suggested, I like baseball a lot. My dad is from the Bronx, so I grew up to be a Yankees fan as well. Lou Gehrig, over his kind of early career from this batting average from 1925 to 1937 was roughly 340. In 1938, which was the year before he was diagnosed with his ALS, it dropped to 295. I think most people would agree that 295 is really an excellent kind of overall batting average for any population that you take off. And this is exactly what the clinical challenge is. That was really a meaningful decline, but it wasn't against his personal performance level, but rather against some sort of population average. So let me close with a few key takeaways. I want to emphasize that certification matters and it should be done. Despite the overall ceiling effect, errors are common in healthy individuals, and domain labels that are included on the tests themselves don't really necessarily represent accurately what the specific items are measuring. The use of a single cutoff can mislead, and scores have to obviously always be interpreted within the clinical context in which the evaluation is being performed. And importantly, the MoCA does not replace comprehensive evaluations. Normal scores do not rule out impairments. Low scores do not always indicate impairment. And the MoCA test itself is designed to be a screening test. So it maximizes sensitivity, not diagnostic specificity. So we only have a minute or so left, so I'd like to do one final question to see what people's thoughts are. If a patient scores 28 out of 30, but the family reports significant decline, what are your next steps? What do you do? Reassure the family that the test is normal? Repeat the test in 6 to 12 months? Rely more on clinical history than the score? Or order neuropsychological testing? Thank you all for the correct answer of get a neuropsych. These are all reasonable things to do to varying degrees, certainly the repetition at times, but oftentimes the neuropsychological testing is an appropriate next step because it has a more comprehensive survey of behaviors, and it also has better statistics associated with it if it needs to be repeated down the road in terms of taking a look at interval change.
Thank you so much, Dr. Lauren. That was an excellent discussion. I don't know if we have any other questions or comments from the audience. I don't think we have any questions on the chat. And please complete this part. Thank you.
Okay, so I guess real quick, next month, Canvas Kemp is going to be taking a look at a topic called Just Join Them, Improving Care Through Improv. And then finally, I'd like to put up a little QR code to claim your credit. So I thank everybody for their time today, and I'm always happy to take any questions by email offline. So thank you very much.
Thank you so much. Excellent talk. Thank you, everyone.
Thank you.